Hello, can you hear me?
Yes, sir, I can hear you.
Okay.
Thank you very much. And good
Thank,
afternoon, sir.
thank you for allowing me to give online talk. You saved 3.5 hours to me, and you have improved the AQI of Delhi NCR by not driving to your place.
Thank you. So nice of you, sir, for joining. Thank you very much.
So let me not waste time. Firstly, welcome all the students to this wonderful course which you are undertaking at World Laparoscopy Hospital. A few words about this course. This is a very unique course in the world, and you have made the perfect choice to come here to learn minimal access surgery. Dr. Mishra is doing a fantastic job, and he's a global pioneer in teaching minimal access surgery, and he has taught thousands of students and surgeons across the world. So, without wasting any further time, I will start with sharing my screen.
Sir, you are also my teacher.
Oh, that's an old story now. Okay, can you see my screen?
Yes, sir.
Uh, yes, sir, we can see that.
You can see the screen. So today I will give a talk about why and when robotic bariatric surgery. So there are a lot of difficulties faced when we are doing bariatric surgery, especially in the super obese patients. So there are heavy and thick abdominal wall muscles. There is more pressure and carbon dioxide inside the abdomen because of that. There is torque to the surgeon's arms, which can lead to fatigue and errors. More intra-abdominal fat, large liver, steep head-up position with its own difficulties, especially for the anesthetist. Hence, dissection, visualization, and suturing becomes challenging and risky at times. So let's see a video of a totally robotic bariatric surgery. This is being done on the XI Intuitive Da Vinci system. So surgeon sits at the console, and what you see now is the console which has got login details. There are controls of the console whereby we shift things around and make a personalized setting for your armrest and the view box. This is the view box on the top. So we have two types of robot, one which has a view box and another one is known as open console, like you have seen in Dr. Mishra's OT of the other system, that is the SSI system. Now energy for pedal devices. Now this is more or less similar for all robotic systems. So you connect right and left hand to the energy. You use your foot to change between arms, control the camera. So all those controls are there on the foot. Having a look at the robotic arms. So these are the robotic trocars which you can see there. And these are similar to our laparoscopic trocar. The difference here with the instruments is that these instruments move in 360 degrees, which is something not possible by human fingers or by laparoscopic instruments. So that is a great advantage both for dissection as well as suturing. So once this instrument goes inside the abdomen, it is controlled through that console. So this is a 270 kg patient in whom we are doing bariatric surgery. That is the trocar which has been put in. And then we would put in this telescope, which has actually two telescopes inside, giving us the 3D vision. So once the telescope is put inside and all our trocars are placed, the robot is now wheeled to its position. So that's wheeling of the robot, bringing it to the head end of the patient. And bringing the robot to the right place to then connect it to the system. Like that. That's another view. Once the robot is there, we connect this what is known as docking of the robot. So the robotic arms have been connected to the cannulas, and then our surgery is in progress, as you can see on this small monitor of the robot. The instruments are inside and they are controlled by the surgeon at the console. So surgeon controls the instrument movements, as you can see there. This is a robotic stapler, and this has a grade 1 AI in it. So it actually feels the thickness of the tissue and tells us what kind of cartridge has to be used. So as you can see, this stapler is now being introduced through one of the robotic arms, and it is connected to the surgeon's console. So now if you look at the screen, it will show you at number 2. So look where number 2 is written. Number 2 is the stapler there, and what it is doing is it is checking for compression, and it has decided to use a blue cartridge. It has been clamped and now it is being fired. Look at number 2 there, pause for compression. So the stapler is pausing for compression while firing, and you can also see that the stapler is rock steady. It does not move at all during the firing. And all this is controlled by the surgeon sitting at the console. So if we go by history, human beings have always been reluctant to adopt new technology. And this reminds me of my days as a registrar in Charing Cross Hospital, London in 1992, when we started laparoscopic cholecystectomy surgery. And these are the type of publications which we used to see: threat or opportunity, milestone, is it a dangerous innovation? But we all now know how laparoscopic cholecystectomy has become the gold standard for gallbladder surgery. Early experience has been there with 2-stage laparoscopic Roux-en-Y gastric bypass in the super obese, and now with robotic we can do it in a single stage. So contrary to popular belief, robotic surgery is not more expensive. One robotic surgery costs less than 2 laparoscopic surgery in the super obese undergoing bariatric surgery. So this is, what we used to see. Now there have been studies. So these are meta-analysis of over 10,000 patients undergoing robotic bariatric surgery. The studies show no difference in complications, similar outcomes, no leak in robotic, 3 leaks in laparoscopic group, similar outcomes, lesser stricture rates in robotic group. So what are the 10 reasons to do robotic bariatric surgery? Now, one, as you see here, I can lift the abdominal wall up, what I call as a robo lift. You can see the abdominal wall being pulled up, and this creates extra space inside the abdomen for us to be able to do the surgery. High definition and complete 3D vision, as you can see there. Then the 270 degrees angulation of the instrument, making the retrogastric tunnel. The tissue can be aligned with an obstructed view because you can bend your instruments away. The staplers can be fired manually also. You saw the robotic stapler being fired earlier, and this is a manual firing of the stapler. And there you can see the retrogastric window being made. And like human fingers or hands, you can see how the instrument bends to create this window. Now, these are some things which are very difficult to do laparoscopically. It takes much longer time. However, with robotic, surgery becomes faster because of these articulating instruments. Then there is no cannula torque or bruising because the cannulas move at a fulcrum. So there is no bruising of the abdominal wall, which is what happens with laparoscopy. Hence, pain is less in robotic surgery. All three instruments are under surgeon's control. These blunt, atraumatic fingers of the robotic instruments are there. The stapler can be fired, and you can actually bring and align the tissue nicely with the articulating fingers to give us a good angle. As you can see here, now there the stapler is being fired from the right side of the abdomen. All this alignment and repositioning becomes much easier with these instruments of the robotic system. Finally, suturing is very easy. We can do a front hand, back hand, top to bottom, bottom to top suturing very easily. As you can see, it's an accurate, precise, tremor-free suturing which we get here. Methylene blue leak test is done at the end of the surgery. And what you see here, methylene blue has been instilled, and this is going to do a leak test. Then you do a final check of the suture line, and what you have just seen is a gastric bypass surgery which has been performed. So I'm proud to say in 2013, we had the world's first robotic one anastomosis gastric bypass done by me at Indraprastha Apollo Hospital. This is Dr. Robert Rutledge, to whom I dedicate this publication. Incidentally, Dr. Robert Rutledge is no more. His last lecture before he died was at the World Laparoscopic Hospital Conference, which was held earlier this year. So in MGB OAGB pouch, now for those who know a little bit about MGB OAGB, when you have a pouch of 20 centimeters and you do an anastomosis of 6 centimeters, you are actually taking the intestine 14 centimeters to the gastroesophageal junction. So how do we ensure that you have a long pouch? And the best way to ensure is to do an end-to-side anastomosis, as you see on the right side of the screen. And this is best done by robotic surgery, as you can see here. Now, we make an opening at the bottom of the pouch. After which, we are doing an end-to-side anastomosis. That's an indocyanine green test which we have done. And this can be done single layer because of the accuracy and precision of robotic suturing. That's a Cornell stitch being put at the end of the one layer of suturing. And then we go back, pass a gastric calibration tube across, do a indocyanine green vascularity check, close it up, and finally do a leak test. So that's an end-to-side anastomosis. So robotic digital interface, it has been shown to be ergonomically comfortable for the surgeon. Hand control on telescope and 3 instruments, everything is there. Foot control on energy devices. The camera is stable and there are controls for all 4 robotic arms. The robot removes counterintuitive movements, as you saw, and instrument tremor in a 3-dimension viewing platform. The system uses instruments with a total of 7 degrees of freedom, including X, Y, Z, tip positioning, shaft rotation, wrist pitch, which is up and down movement, wrist yaw, which is left and right movement, and the grip. 7 degrees of freedom, multi-directional, precise and tremor-free is what makes the robotic suturing so good and safe. Comparing cases, I compared 30 cases of mine, step 1, step 2, step 3, and step 4. And what we found was that the step 2 and step 3 in the robotic, which is the yellow, takes less time than the laparoscopic group. Then we talk about docking time, and what you see here is the robot getting docked. So what you see here, you've got a clock there, and that's the robot being brought in. Now I'm showing an old video purposely because I'm showing you how the docking never took us very long. That's because there is good coordination between the staff and everyone. So that's the telescope which has been placed inside, and you can see the arms being docked. That is the fourth arm, which is being prepared. And you can see how the entire docking has taken about 52 seconds, less than a minute. That is less time than what my nurse takes to go find a suture. So when I started gastric bypass surgery in 2012, you can see that red circle. It took me 214 minutes. Now this is the My Intuitive app, which is centrally there in USA. It tells you the details of all surgeries done by all robotic surgeons across the world. So you can see in 2012, I took 214 minutes to do gastric bypass. My anesthetist, my junior staff, nurse, everybody was very unhappy that, sir, you take 1.5 hours to do laparoscopic bypass surgery. Why are you taking so long to do robotic surgery? Why do we do robotic surgery? So this is, as you can see, case number 17. You can see on the top, #17. And this is in 2016, case number 97. And you can see the time here is 33 minutes. So after the learning curve, it was taking 33 minutes to do the gastric bypass surgery. Laparoscopically, still, I cannot do it in less than 1 hour. So all I am trying to say is that don't get discouraged by the initial learning curve. After you have crossed the learning curve, your staff has crossed the learning curve, complex surgeries by robotic always takes less time. There is enhanced surgeon capabilities because it transforms the surgeon's skill development, enabling rapid progression from basic to advanced bariatric procedures. Accelerated learning curve. Surgeons achieve sleeve gastrectomy in just 20 cases with operative efficiency attained in 12, much faster than laparoscopy. Complex case mastery due to the 7 degrees of freedom and 3D visualization enables surgeons to tackle super obese patients with equal precision to standard cases. Revision surgery. There is a 3.7-fold increase in robotic revisional surgeries, and this demonstrates enhanced capability for complex cases with fewer complications and shorter hospital stay. High BMI patient management due to enhanced visualization and consistent instrument performance regardless of BMI enables confident management of challenging anatomy. High obesity and diabetes burden. These are the other drivers which require a lot of these surgeries. Then other driver is also medical tourism. So robotic platforms attract international patients seeking cutting edge care. So if you have robotic surgery in your hospital, you will get more medical tourism patients. And government and private sector. So many countries are positioning robotics as part of healthcare modernization and industrial innovation. So in many countries, they buy robot for government hospitals just to show public that, look, we are investing in advanced technology and our country is at par with other countries. So government sector push is there. Private sector push is there because, they can show to their potential customers and patients that we've got the latest advanced technology. So these are the other drivers which also push the implementation of robotic surgery in many countries. As far as training is concerned, there are simulators which are there, as you can see there. Now this is a robotic simulator for the intuitive. Then they have their buses which they bring to the hospitals and you can actually learn. We also have dual console with our intuitive systems. And here you can see a surgeon. This is at SMS Medical College, Jaipur, where I had gone. And surgeon is sitting on one console and I am sitting on the other console. So the moment I touch an instrument, the instrument control comes to me and I can always give the control back to the surgeon. So this is a fantastic way of training. It is like training pilots, and in no surgery, whether open surgery or laparoscopic surgery, can training be so well attained. We also have cadaver training across India at various centers where the cadaveric robotic training can take place. This you are seeing, we are doing this training at Chennai, at MGM Medical College. Multiple robots are there, and various surgeons are being trained on cadavers for their robotic training. Now, the lease model financial revolution is there, which breaks capital barriers. Traditional obstacle has been there for 2 million system cost was beyond reach of many institutions. So the lease eliminates large upfront investment, enabling resource optimization, flexible terms of payment. So upfront equipment costs ranked as top adoption barrier. Now the leasing overcomes this. Economic transformation has taken place because there is volume-based scaling. Lease payments are aligned with procedure volumes. Risk mitigation is there, more flexibility if volumes don't develop. Comprehensive packages is there, which includes bundled training program, maintenance, and support services. Finally, innovative models are there where per procedure fees is paid to the robotic company, and it is also outcome based. So my personal recommendation, advantage of robotic surgery in bariatric is most prominent in revision surgery, bariatrics in the super obese, and for the learners. If the learner learns on robotic surgery, his or her skills will also show when they do laparoscopic surgery. So change is inevitable, growth is optional, my dear friends. You can use the robot, as you can see on the left, to do puja or worship with diya there, or you can use the robot, as you can see on the right, to open a beer bottle and fill it up without spilling a single drop. With that, I come to the end of my presentation. If there are any questions, I will be very happy to answer them.
Thank you, sir. Thank you very much.